Good afternoon. Actually, any discussion regarding the device, drugs, or anything about the heart failure starts with this very popular slide, as because these slides highlights the classification of the heart failure, eco-based classification. The importance of this slide is that this slide has clearly classified the heart failure population, as because heart failure population is a heterogeneous group of the patients. It is very difficult to classify the patient uniformly. So after a long trial, it has been classified just on the basis of the echocardiogram to simplify, to divide the patients for selection of the drugs and devices. So this is another importance of this slide is that we can see that is the main discussion, the main concentration of the heart failure is focused on the reduced ejection fraction. But this group of the patient only comprises the 50% only. Only 50%. The rest 50%, the moderately reduced ejection fraction or the preserved ejection fraction has actually got the less attention since beginning. Nowadays, as the times are going on, the importance, the clinical importance of the other two groups are becoming clear and clear. So this is the importance of the, and this is the actually the timeline of the main heart failure trials, randomized trials. We can see the heart failure trials. It is not too old. It is only in the second decades of this century, that is in the year of the 2014, when these results of the study is published and the revelations of the treatment of the heart failure starts. So it is only several years old of the revolution of the treatment of the heart failure. And these are the actually name of the studies, and finally these are the outcome of the studies, that is the beta blocker, spironolactone, different kinds of the glyphosines and the RNA. These are the outcome of this, all the randomized big clinical trials, and it is started from the 2014 only. And most of the studies are concentrated on the reduced ejection fraction. And this is again the very popular slide. We see there are lots of the drugs, huge number of the drugs in case of the heart failure patients, but only these four has been classified as the foundational therapy or the fantastic four, as because only these four has got the mortality benefit. The other drugs are the adjunctive therapy, and they have got the symptomatic benefit, no the mortality benefit. These are the only four drugs that has proved their mortality benefit in their previous landmark trials. So these are the actually the fantastic four, and the mortality benefit using the drugs are additive. And this is not the simple equation of addition. This is not the simple equation of mathematical addition. It is statistically additive, that the number of the drugs are used if possible, the benefit will be additive. So the benefits are additive, but despite the introduction of these drugs, these are the actually, this number highlights the benefit, actually ACE inhibitor 16%, beta blocker 34%. These are the benefit of mortality reduction we can got from these drugs, and the benefits are additive. But despite the use of the drugs, additive benefits, still significant number of the patients has got the bad prognosis and risk of the sudden death. And particularly, this is very much important, that is after diagnosis, up to 25% of the patient may have the cardiac death. And among this cardiac death, 50% of this cardiac death are the sudden cardiac death. So diagnosis of the heart failure within 2 years, 25% of the patient may die, and 50% of the patients may have the sudden death. And this was the great challenge again for the heart failure patient management. And because of this, these are the number of the trials for the secondary prevention trial and the primary prevention trial. And these are the name of the trials, these are the very much popular and landmark clinical trials. And all the trials were targeted for the reduction of the sudden death, particularly comprising with the either device or comparing benefits with the drug versus device. And you please note that in all the cases, the inclusion criteria of the diseases, actually those who are got the sudden cardiac, that is the arrest survivor or has got the VT or the chances of the VT or the inducible VT, that is those who have got already experienced the sudden cardiac death or has got the high risk of the sudden cardiac death. But still, the main information, the main message, what I want to show you is that these are again a group of the patient, you see, these are the again group of the patient, that is the post-MI patient, they are less than 40 days, non-MI less than 3 months, life expectancy less than 1 year, insistent VT, reversible ischemia. Still again, among the heart failure patients, significant number of the patients remain unchallenged. Still they are the victim of the sudden cardiac death. This trial has not included these groups of the patient, and this actually the indication of the ICD is not indicated for this group of the patients. So what can be done for these groups of the patients and what is the resource? And it is not only the arrhythmic death, the death of the heart failure patients after the diagnosis also depends upon the another important factor, that is the ejection fraction. So it is another again main challenge how the ejection fraction of the patients can be improved, and targeting this challenge. These are the list of the number of the major RCT clinical trials of the heart failure patient. These are the name of the trials, and please note that in all the cases, you see, these are the inclusion criteria. Symptomatic patient, ejection fraction less than 40%, and ECG criteria equal to or more than 120. And depending on this criteria, only less than 1/3 of the patient, heart failure patient, may be included for these kinds of the therapy. That is less than 1/3 of the patients. And those who are included and given this therapy, it is not straightforward that all the patients will be benefited equally by these kinds of the therapy. The benefits of the therapy by these kinds of the, that is device therapy, is not straightforward, homogeneous and uniform. It depends on the several factors. Particularly it is the ECG and the echocardiographic parameters that depend the which groups of the patients will be benefited. And on these two parameters, that is the likelihood of the patients has been classified by this way. That is, this is a good chance that these patients may be almost sure the patient will be benefited. This is a group, there is a moderate chance that the patient may be benefited. And these are the group on the right side, there is a less chance of the patient benefited. So, this is clear that despite some of the patients may fulfill the criteria for the heart failure improvement and for the that is the selections of the CRT therapy, but still nearly 1/3 of the patient may not show the benefit. And at the 6th month after the implantations of the device, that is the CRT, if we analyze the patients, there may be these are the outcomes. After the implantation of the CRT, at the 6th month, there may be, these are the outcomes. That is, the patients may be super responder or good responder or non-responder, these different kinds of the therapy. And depending on these endpoints, actually in all the studies by which this classification has been made, just depending on these endpoints, by using these endpoints, these are the parameters which has been used in all the studies, and depending on these parameters, the patient has been classified these several parameters. And the patient who getting the CRT therapy even does not show these kinds of the improvement, they are considered as the non-responders. So these are the, so finally, this is the summary given by the ESC, that is the classification or triaging of the patient for selection and for the different kinds of the therapy. But still, these are the groups of the patient, that is the ejection fraction less than 35, but still the QRS is less than 130 and patient is non-responders. What can be done these groups of the patients? This is another kind of the therapy that is emerging, recently getting popularity, being used worldwide, but still it is a class 2 indication, is because there has been no randomized clinical trials. The trials are going on. So this is the kind of the therapy that is called the His bundle pacing. This can be done for the heart failure patient, and these are the groups of the patient, that is non-LBB, RBB or CRT responders. These groups of the patient may be benefited with these kinds of the therapy. And not only this therapy can give the solution, there are different problems, there are different kinds of the outcome, and depending of this outcome, the connections of the lead with the devices may be used in different ways by the that is the operators in their settings, and depending on the settings, by using the therapies can be done in different ways, and these are the actually options. That is the His bundle pacing, hot CRT and lot CRT. Actually this is the same device. Just depending upon the connection, that is which lead where you will apply, either in the His bundle area or the septum and or the coronary sinus, depending on this name has been done. But so these are the different kinds of the trial, and still we are confused which patient will be benefited with which kinds of the therapy. So these are the problem. So finally, it is not only the reduced heart failure problem by this slide. I think this is the last slide, you see. So you can see the significant number of the patient, you see, significant number of the patient, this bar at the different age groups. This is the yellow is the heart failure with reduced risk infection. This is the moderately reduced, and this is the preserved risk infection. In all the groups, the mortality and the hospitalization rate is almost similar. But there is little options for these groups of the patient, as because you see these are the only options for the heart failure patient. That is drugs for the mortality reduction, no. Drugs for the recurrent hospitalization in case of the diastolic failure, yes. Device for the diastolic heart failure patient, no, there is no devices. And lifestyle and the comorbidities of these heart failure patients, yes, okay. So these are the limitations of the heart failure treatment, particularly for the preserved ejection fraction. So there are something more to show, but the time is short. So I can conclude at this point. Thank you very much.